Hello, busy schedule.
This meeting is being recorded.
Thank you. Thank you.
Yes. Shall we start, sir?
Yeah, sure,
Uh,
sure.
Yeah.
Debalina, just a second. Debalina, do you want to start the session?
Sure, sir, sure. If Dr. Christopher stops his sharing,
Yeah, it is sharing now already. You can see that.
you can stop your sharing, sir. I will play a short video of clinic, then we'll start.
Okay.
Yeah, thank you so much.
Sure.
I hope I am clearly audible.
Yeah,
Yeah, you're clearly audible, madam.
Okay, sir. Thank you. A very good evening and a warm welcome to all the doctors present here in this session. Team Clinic is very proud to be a part of this journey as a digital partner. Clinic is India's largest live digital CME and doctors generated medical content platform. So here is a short glimpse of Clinic. Thank you so much all for your patience. You can always find us on Google www.com. Lots of live sessions conducted by eminent speakers across the globe. We have MedWiki services, which is medical Wikipedia for doctors. In your leisure time, you can play polls and quiz through our platform also. So without further delay, now I would like to welcome Dr. Praveen, sir, to start with the scientific session. Over to you.
Thank you, Debalina. Thank you. Good evening and welcome to one and all. I am Praveen, doing my pre-final MBBS from Madras Medical College, Chennai, State President of SNO Tamilnadu. I feel really elated to see medical students and doctors from across the length and breadth of this nation have joined for this webinar. IMA JDN has been doing plethora of webinars on various topics with the objective of disseminating knowledge and keeping the medical community informed and updated. IMA JDN, in collaboration with Student Network Organization, Tamil Nadu, under the guidance of Dr. Abulasan sir, presents the webinar on topic Varicose Veins and its surgical interventions. Their position, the patrons of webinar are Dr. Abulasan sir, a well-acclaimed pediatric surgeon from Erode. Sir is the chairman of IMA JDN Tamil Nadu and also IMA Tamil Nadu State President-elect for 2024. And Dr. Manikandan Mohandas sir, the state convener of IMA JDN TN and immediate past national joint secretary, IMA JDN. I request you to request you to welcome the speaker for the day, sir. Up to you, Karthikeyan, sir.
Okay. Good evening, everyone. I'm Dr. Venkatesh Karthikeyan from AIMS Patna. So first of all, I would like to thank speaker Dr. Christopher sir for agreeing immediately on our request. Actually, I did my MBBS from Vedamal Medical College, Madurai. So during my second year itself, sir used to take me to OT, that too in night times, late nights. Sir used to risk taking a second year student and he used to take me inside OT. He's the person who taught me how to do proper hand washing before surgery. He gave so much opportunities and like probably that's one of the trigger for me to do something good in medicine. So thank you so much, sir, for not only me, but for many people, even for MBBS students, even for SRs and assistant professors. Sir used to teach and he used to be very helpful and supportive. And currently, sir is extremely busy. He has done a lot of fellowships and he's a very busy practitioner. And it's a blessing for all of us that sir is here sharing his knowledge today. With this, I would like to thank and welcome Christopher sir to take over this.
yeah, yeah.
I feel honored.
I request Praveen to give a formal introduction of sir.
I feel honored to introduce the speaker for today's session, Dr. Christopher Sir, who has done his MBBS, DNB in General Surgery, MNAMS, FIAGES, FMAS, FAC RSI, FICS USA, FACS USA, FAIS, FRMS from Taiwan, FRSPH UK, DMAS France, FMIS IRCAD, FIRCS WALS, F.MAS, D.MAS from WALS, FALS in upper gastrointestinal, colorectal, bariatric, hernia and robotic surgery, and is a consultant, advanced and minimally invasive bariatric, GI and laser surgeon. Sir specializes in endoscopic, laser, laparoscopic and robotic surgery, and also a board certified surgeon with more than a decade of experience in all aspects of laparoscopic and minimal invasive surgery. Sir also has the distinction of being the first qualified robotic surgeon in South Tamil Nadu. Dr. Christopher Sir is the founder and CEO of BariOSS, a bariatric, obesity and metabolic surgical specialty center, which has its branches at Tirunelveli, Nagarkoil, Tenkasi, and Thuthukudi, as well as being a visiting consultant in several acclaimed hospitals across India, and currently honorary assistant professor of surgery at Bharat Medical College, Tambaram. Sir has so much in his resume that it would be impossible for me to cover in a single session. Sir, I profoundly apologize to you for the short intro, sir.
That's okay. That's okay. I think we
So
can start
without
the
any
session,
further
no
delay,
problem.
I request Dr. Christopher sir to take over the session. Yeah, you can take over the
Sure,
session.
sure. I'll just share my screen. Just let me know if it is, you can see that, okay?
Yeah.
Is it visible?
Yeah, it is visible, sir. It is visible.
So can I proceed?
Yeah, you can proceed, sir.
Yeah, thank you, Venkatesh, for the intro. And I remember those days where I was teaching you, and also Velamal days was the best. You also know that. As a student, I have seen you. Now I am very happy to see you as a postgraduate in AIMS Patna. And also thank Praveen for such a wonderful intro. I think there is a slide is not moving. Just a minute. We'll just share again. Yeah. So this is all about me. I think Praveen has already introduced. I'm a consultant, advanced minimal invasive bariatric GA and laser surgeon, and I'm a CEO and director of BariOSS centers in Chennai, Madurai, Tirunelveli, Thuthukudi, Nagarkoil, and Tenkasi. What is BariOSS? You will see in all over my slides. It is bariatric obesity and metabolic surgical specialty. I specially got trained in bariatric, so my practice is mainly of obesity. And as such, I'm the only bariatric surgeon in the south of Tamil Nadu as of now, qualified. So these are the other specialties where bariatric, metabolic, colorectal, hernia, upper GI, and the other advanced minimal invasive. And I also do the single port surgeries and also laparoscopic thyroidectomy and laser surgery for varicose veins, piles, fissure, fistulas, endoscopy, CP, and also robotic. And whenever there is a opportunity. So now, because I'm also trained in varicose and laser, so they wanted a talk in varicose vein. So let's see how I can go through. So what is varicose vein? So varicose veins are dilated, tortuous, elongated, superficial veins. So and that are usually seen in the legs, and it comes from the Latin word varix, which means twisted. So to know more about varicose vein, so you need to actually know about the anatomy. So anatomy of lower limbs. So we shall see in these headings: superficial veins, deep veins, and perforators. So superficial veins, mostly the two veins, which is very important, which is the small saphenous vein, which usually runs from ankle to knee, and the great saphenous vein, which runs from ankle to groin. There are different terms which they were used before, but now everything has been changed into only these two standard names. So these are deep veins: tibial, peroneal, popliteal, and femoral veins. So these are the deep veins in lower limb. And the perforators, so you can remember in this, hunt for death by chocolate. So hunt is at the thigh level, and dod is at the mid thigh level, and boiled is just below the knee, and then cocked is at the ankle. So again, when I'm explaining about the perforators, you will know in detail. So this is how perforators are arranged, and these are the main important perforators. Other things, there are many perforators in fact, but these are the names you should really remember, because these things are very important in your clinical exam as well as in your entrance exams. So how does the blood flow from the foot to thigh? So the dorsal venous arch, that is where initially the blood from the digital vein comes in, and then it goes to the medial marginal vein or the lateral marginal vein. And from the medial marginal vein, it ascends as the GSV. From the lateral, it ascends as the SSV. And then that goes into the femoral vein. The GSV connects to the femoral vein and continues, and then the SSV goes into the popliteal vein. So this is the way the blood flows from foot to thigh. So this is the dorsal venous arch of foot. So it lies in the subcutaneous tissue over the heads of the metatarsal with convexity directed distally. So it is formed by the union of 4 dorsal metatarsal veins, as I told you, and each dorsal metatarsal vein receives the blood in the clefts from dorsal digital vein. So how does the blood flow? In the sole, the blood flows from deep veins to the superficial veins in the dorsum. But in the leg and thigh, it goes from the superficial to the deep veins. So now you should remember only the leg and thigh. The sole we are not concerned about. That is all in anatomy part. So now just listen to the leg and thigh. So superficial to deep veins. So this is the GSV, which is the great saphenous vein. It begins from the medial side of the dorsal venous arch and supplemented by the medial marginal vein, which I already told you. It ascends about 2.5 centimeter anterior to the medial malleolus and passes posterior to the medial border of patella, as you can see in the picture. And then it ascends along the medial side of the thigh. It penetrates the deep fascia of the femoral triangle and pierces the cribriform fascia. And then it enters the saphenous opening and drains into femoral vein. So this is the main course of GSV. This is very, very important when you have to examine a varicose vein patient. You should know about GSV very well. So these are the tributaries of GSV, which is the superficial epigastric, superficial external pudendal, and superficial circumflex iliac. So these three are again very important because this has surgical importance. I'll tell you about that later in the later slide. So this is again anterior accessory saphenous vein. This is actually not so important in the MBBS level, but then as a surgeon or as a clinician, you should know because this is a vein which actually causes recurrence of treatment after varicose vein surgery. So usually we ligate the great saphenous vein or maybe laser ablation of the great saphenous vein. But if there is a anterior accessory venous vein, then obviously there will be a recurrence. So we should always tell our radiologist or our radiology friends to look for this anterior accessory venous vein so that we can ablate that vein also or we can ligate that vein also. So the short saphenous vein, as shown in the figure, it is on the lateral side and it runs, it accompanies the sural nerve and ascends along the midline of the calf and it enters into the popliteal vein in popliteal fossa. So the SSV and its variable termination. So SSV is not like constantly, it is terminating only in the popliteal vein. It can actually ascend in the upper 1/3 and along join the GSV, and it may bifurcate one in the popliteal vein and one in the GSV, and may end in the GSV or in the deep vein of the leg. The main accessory or the main SSV variation I want to focus is Giacomini vein. This is actually a variation of the SSV which continues through the thigh. If you see the image from the SSV, if you see one of the vein, it just ascends up and then it joins the tributaries on the near the thigh. So this plays a contributory role in the development of chronic venous disease. Again, this is again one of the vein which needs to be known by the surgeons or the clinicians, and you have to insist the radiologist to look for any accessory veins. Like as I told you in the GSV, this is one more, like SSV also has a accessory vein. So these are the deep veins. They are actually within the deep fascia. They are surrounded by powerful muscles. So the blood flow in this vein will be greater and in pressure and then the volume. It accounts about 80 to 90% of the venous return from the lower limb, and it accompanies the artery. Below the knee, it will be like having different variety of communications, and above the knee, it will be only one single vein. Okay, and the perforators. So these communicate between the superficial veins to the deep veins. So what this perforators does, it allows blood flow only from the superficial to deep. So if there is a return or if there is a problem with the perforators, that is where the blood flows to the superficial vein, then that is where varicose vein comes. So this is again, the perforators plays a very important role. So these are the perforators, as I told you. The lateral ankle perforators, you can see in the image also. Medial ankle perforators are the cockets, and the gastrocnemius perforators around the knee is the boyd, and the mid-thigh perforators are the dod, and the hunter's perforator in the thigh. So as I said, you can remember from the top, hunt for death by chocolate. So depending upon whatever you want to. So that is the way it is remembered. So, and then the valves in the GSV. There are around 10 to 12 valves in the GSV. So one valve is just before the GSV pierces the cribriform fascia, and there is a valve at the SFJ. This is very important because if that valve is incompetent, that is where the entire GSV becomes incompetent, and that is where there will be tortuous dilatation of the veins. So that is where we also can easily see the visible varicose veins also. Okay. So these are the factors which helps the venous return. So first one will be the negative intrathoracic pressure, and then the suction action of the diaphragm during the inspiration, and the cough muscle actually acts as a pump. It is actually a second heart. For example, how the heart pumps, the same way the cough muscles also pump each time, and it actually pushes the blood towards the heart. And then the transmitted pulsations from the adjacent arteries. And then these valves maintain unidirectional flow. So the valve does not allow the blood to come down. If it is coming down, that is where you have the varicose vein, or that is where there will be valvular incompetence. Okay. So what causes varicose vein? As I told you, the veins have one-way valves. So to prevent the backward flow. So the correct functioning of the venous system depends on a complex series of valves. So these varicose veins in the legs are mainly caused by the weakening of the veins and the valves in the GSV or the SSV. So when there is a malfunction, the blood begins to collect in the legs. That results in buildup of pressure. So that is where the veins looks enlarged, knotted, and visible near the surface of skin, and that is called as a varicose vein. So this is a picture where you can see. So ideally the competent valve should allow blood only to go upwards, and if there is an incompetency, there will be reverse of flow, and from superficial to deep, ideally it has to go. From deep to superficial it comes. That is where you will see the varicose vein. So SFJ, which is very, very important for clinical, for MBBS students, where you need to mark, and all your varicose vein test and all is done based on this SFJ. So SFJ, the major valves which dysfunctions in varicose vein are SFJ and SPJ, both valves. There are two valves, one is on the thigh, just around the thigh, and one more just below the knee. So these are the main thing. And then the termination of point of GSV into the common femoral vein is located proximally at the joint. That is where the SFJ, which is around 2.5 to 4 centimeter below and lateral to the pubic tubercle. So there is a very important landmark. So you should definitely know this during your exam. If you don't know about SFJ and you have a varicose vein patient, that's all. So the exam will not proceed further. So we should be very, very careful. And the pathophysiology. So till now I have told about the anatomy. So you know what is GSV, you know what is SSV, you know what are the perforators, you know what are the calf muscle, you know what is the deep veins and everything. So now the pathophysiology. So what happens in healthy veins, the flow of venous blood is through the superficial system into the deep system and up the leg and toward the heart. So the one-way venous valves are found in both systems and perforating it. So when there is an incompetence in one of the valves, that will lead to the unidirectional flow, and that causes ambulatory venous hypertension. So which means that the stasis of blood in the vein that causes excess pressure, and that actually forms a varicose vein. So this is the one. The blood flowing in the left side, if you see blood flowing in one direction, that is the ideal thing, which is normal vein. When there is a blood flow on both directions, there will be swelling around the vein and also damaged valve. That is a varicose vein. So you can see there are two different types of pressure. One is hydrostatic pressure and one more is a hydrodynamic pressure. The hydrostatic pressure is usually seen when there is a incompetent SPJ or SFJ. Okay. And the hydrodynamic pressure, which is actually because of the incompetence in the perforating veins. So the calf pump mechanism, which helps to empty the deep venous system. If the perforating vein valves fail, the pressure generated in the deep venous system by the calf pump mechanism, which is transmitted into the superficial system via the incompetent perforating vein. So ideally the calf muscle pump, the pressure has to be kept inside in the deep venous system. So when that goes to the superficial system, that is where the pressure is more. So what happens? Venous hypertension. So the venous dysfunction, it continues, and then that causes venous dilatation, and then greater valvular insufficiency, and that causes a local dilatation, and then adjacent valves subsequently fail. Like if one valve fails, and then gradually every valve starts failing, like from below to upwards, and the entire superficial venous system is incompetent, right from the lower medial aspect till the SFJ, everything is incompetent, perforator and valvular dysfunction. So that causes varicose vein. So now you know something about the anatomy, the pathophysiology, the pressure changes and everything. So now we'll go into the proper varicose vein. It's the investigations and the treatment. So the varicose veins are twisted, enlarged veins, and any vein that is close to the skin surface can become varicose. So varicose veins are not only like these are seen in the legs, but the same thing can be seen in case of varicocele in the scrotum, and also esophageal varices if you see the venous dilatation, and also in the rectum as hemorrhoids. So everywhere it is the same mechanism. Everywhere it is the same venous hypertension. Okay. So the risk factors of varicose vein, age actually. So as you age, there will be wear and tear on the valves. So that controls the blood flow. And women are more likely to develop the condition more because hormonal changes before a menstrual period or during pregnancy or menopause might be the factor which relaxes the vein walls. So again, hormonal treatments like birth control pills might also increase the risk of varicose vein. So when you take a history, all these histories are very important. what is the age of the patient, and what is whether the patient is a female, whether the patient is taking OCP, and whether they are on the menopause time or they are during the pregnancy they had this issue. Because most of the time when the uterus is actually uterus is abutting on the veins, actually that is where there will be varicose vein. So when you ask for the history, many ladies, they tell that they got varicose vein during pregnancy. Most of the time those varicose veins may disappear after the pregnancy, but few will remain. Okay. And then pregnancy, this is what I said, the blood volume in the body increases, and there is a this chain supports a growing baby, but also enlarge the veins in leg. This is the same thing. Family history, most of the time the varicosities runs in families. Okay. And main thing is obesity. As a bariatric surgeon, all my patients who comes for my treatment, they'll be around 120, 130, 140, 150 kgs, and every patient I see, when I examine, they have varicose vein, they have venous ulcer and everything. So the obesity is again a factor. If a patient is overweight and if they reduce the weight, obviously the varicose vein also will drastically will improve. So always make sure that you be on the right weight and you do good exercises. And also again, this long standing and sitting, like for example, traffic police and surgeons like me, and we are all standing for a long time. Even I have varicose vein, but it is the starting stage. So usually I put bandages, script bandages or compression bandages, and I manage. So if it is long time standing or if it is long time sitting, both actually causes a problem. So make sure you keep moving. Okay. So these are the risk factors: genetic susceptibility, and then long periods of standing, long periods of sitting, pregnancy, age, obesity. Even smoking also causes varicose veins, right? So these are the signs and symptoms. They are large, bluish or purple appearing bulging veins, and then swelling of the ankles or feet. And usually as the day progresses, they feel heaviness of the leg, and there may be muscle cramping in the legs, particularly at the night. And then there will be itching in the legs. Whenever you ask patient for history, they may tell, or if you see, there may be scratch marks on the skin. That's how you evaluate. And then burning and throbbing sensations in the legs, discolored patches of skin around the bulge veins. Okay. And the classification of venous disease. These things are there in your clinical DAS textbook, but still I want to emphasize this is even now in the clinical practice, we also look for these things. So CEAP classification, which is clinical severity, etiology, anatomy, and pathophysiology. So this is the classification of CEAP. So C0 will be no visible or palpable signs. C1 will be reticular veins. C2 will be the proper varicose vein. C3 will be edema, and C4 is pigmentation or eczema, and C4b will be lipodermatosclerosis, which means that infection of the subcutaneous, inflammation of the subcutaneous fat. Okay, and then the healed wound is C5, and C6 is the open wound. So most of the time the patients come to surgeons at C2 level, but we have that is common. But then those patients, if they come at C2, usually they will be given some conservative management without surgery, and they become okay, and they improve, and even they become okay. But the other class, the C3 or C4 or C4b or C5, those patients will need intensive therapy. Okay, the open wound also will need a lot of treatment and long duration of treatment. All right. So these are the clinical tests which you already know, which is Brody-Trendelenburg's test 1, which is actually used to evaluate the SFJ, where you need to, I'll explain few, where you actually mark the SFJ, and you elevate the limb, empty the vein, and then you occlude the SFJ, and then you tell the patient to stand. If it is filling, then from above downwards, and it is SFJ incompetence. In test 2, continuous pressure, if it fills, then perforate incompetence. Then modified Perthes, you have a tourniquet, and you tell the patient to walk around without emptying. That is where you find DVT, which is deep vein thrombosis. There will be pain in the cough. Tourniquet test, which is perforate incompetence. Again, you tie multiple tourniquet and see which perforators are incompetent. And Schwartz test, you empty the vein, and then you just make the patient stand, and then you tap down and you feel the impulse on the top. And Fagan's test, you just mark the perforators while standing, and then you tell the patient to lie down, and you can localize the perforator. So these tests you will not be having time to do in your regular OPD. In the future, not as a student. As a student, you are bound to know all the tests, and you need to definitely explain all the tests and also examine in a proper way. So until and unless you learn how these things are done and how how you can explain this to the examiner, passing a varicose vein case is very difficult. So you need to know all these tests, okay? And Saphenous varix. So this is again a dilatation at the top of the GSV due to the valvular incompetence. This is usually not seen in all patients, but then few patients you can see. There will be a swelling at the thigh region. So there's a soft and compressible swelling. It disappears immediately on lying down and exhibits an expansile cough impulse. So when there is a swelling case given to you, especially on the thigh region or groin region, so you will have a differential diagnosis of hernia, Saphenous varix, and you may have some lymph node and all those things. So always have in your mind, if the swelling disappears immediately on lying down, that is a Saphenous varix. The other swelling, hernia, may not come up to this level. So okay, so you need to know to differentiate. Then it comes a varicose ulcer. So varicose ulcer or venous ulcer or a stasis ulcer. This is the common etiology of lower extremity ulceration. It is mostly in the medial aspect. Okay, all venous ulcers are in the medial aspect, and the granulation tissue and fibrin are typically present in the ulcer base. And as I said, there will be associated findings, which is edema, dermatitis, lipodermatosclerosis, which is the inflammation of the fat tissue. Okay, and then these are usually recurrent, and an open ulcer can stay for weeks or years. As I told you, there will be patients coming for dressing for more than 6 months, 8 months, 1 year, 2 years, and until and unless they agree for surgery, the wound will not heal. Okay, I'll explain about that later. So until now, you know what is varicose vein and how to find out clinically. Now let's know how to confirm it. Okay, so the investigations. The gold standard investigation at present is the venous duplex ultrasound that has become the standard of care. All the other investigations right now, it's not so commonly performed. As a clinician, what we do is we just write a venous Doppler, and once the patient comes with the report, in the report we find what about the SFJ competent or incompetent. We'll find out the SSV, and we find out SPJ competent or incompetent, and also the perforators. So that is where it's given here also. So diameter of the affected vein, whether it is a large vein, whether it's a small vein, all those things we can see, right? So the other investigations, as I told you, venography, plethysmography, ambulatory venous pressure, varicography, arm, foot venous pressure, all those things are all. Now, right now, I don't think it is carried out. In some few specialized vascular unit, probably if they want, they will be doing, but not as a routine, it is not done. Only the venous Doppler is done as a routine, right? And then treatment of varicose vein. So the treatment of varicose vein, I have classified into these: the conservative management, wound management and skin grafting, compression therapy, pharmacotherapy, sclerotherapy, and surgical therapy. So the conservative management, everybody knows. First thing, as I told you, weight loss. If you are overweight or obesity, definitely you need to have you need to lose weight so that automatically your varicose vein becomes better. The venous pressure actually decreases and you may actually become better. Limb elevation. Most of the time, if a patient is having the initial stages of varicose vein, you can just tell them to keep 2-3 pillows and just elevate, so that once the limb elevation is done, the pain or the visible varicose vein actually slowly disappears over a period of time. And then the reduced periods of standing. So when somebody is having a job where their standing is mandatory, tell them to take some rest and then continue the work. In that way, the varicose vein can be reduced. So the wound management. So ideally, when the patient comes with a venous ulcer, first thing you should do is a dressing. So the dressing, ideally, you can clean it with saline, and then you need to have a dressing technique that should be clean and aimed for preventing cross infection. Always have a sterile instruments and do dressing. Then the dressing should be very simple, low or non-adherent, low cost, and acceptable to the patient. So if the patient is coming for a dressing, and if the dressing is costing is too high, then the patient will not come back. So it's always you should know to do a dressing where it will be low cost and acceptable to the patient. And there is no single dressing material that is favored. So you need to keep trying many different types of dressings, whatever you have been doing. So mostly the dressings or bandages which is impregnated with the zinc oxide, that will actually provide comfort and promote epithelialization of a healthy granulated and superficial ulcers, right? And the debridement. For wounds with slough, we usually debride. So until and unless you find granulation tissue of any ulcer, you need to just cut out all the necrotic tissues, and you should keep the wound very clean. Skin grafting, we usually advise a patient for the chronic non-healing wounds. Okay, skin grafting is totally done by plastic surgeons nowadays. General surgeons nowadays, we don't do the skin grafting. So this is actually done by them. But when a patient is actually having a non-healing ulcer, it actually involves both the surgeon, the general surgeon doing the varicose vein surgery, and at the same time the plastic surgeon doing a skin grafting. That will give a very good result. Okay. And then here comes the compression therapy. This is a standard of care for venous ulcers and chronic venous insufficiency. So what happens is the compression therapy means that the crepe bandage, or there are different types of bandages nowadays available, which reduces edema. It improves the venous reflux. It enhances the healing of ulcers and reduces the pain. So this is actually apart from the limb elevation. When we give compression therapy and limb elevation, again, the patient will feel much better. Okay. After an ulcer, I see lifelong maintenance of compression therapy may reduce the risk of recurrence. As I told you, if the patient doesn't want surgery, if the patient doesn't have incompetent valves, they can actually be on a lifelong compression therapy, which will actually reduce the chance of recurrence of varicose vein. So this is how it is done, the compression therapy. So if you see that before the compression therapy, the blood flow will be on both sides. But after the compression therapy, the valves are getting tighter and there is no backflow of blood. And so there is a good venous return. So there again, we have elastic compression, inelastic compression, intermittent pneumatic compression devices. So these are the three things which we usually apply for the compression therapy. So the pharmacotherapy, we have flavonoids. Flavonoids is like diosmin and hesperidin. So these are the two combinations or only diosmin. So this is the common drug which is written for varicose vein. So usually whenever we see a varicose vein, initial treatment will be flavonoids until and unless the patient comes with a venous Doppler. Okay. And antibiotics, we just give antibiotics when you suspect some discharge or you suspect some infection on the wound. And then other than that, anti-inflammatory drugs or NSAIDs if the patient is having pain. Okay. So the flavonoids, again, the mechanism of action is this one. It causes vasoconstrictor effect of noradrenaline on the venous wall. So what happens is there will be increased venous return, then reduction of venous hyperpressure, there will be improved lymphatic drainage, and there will be protection of the micro circulation from inflammation. So this is the work of the flavonoids. So what we commonly write is there are two to three different types of flavonoids. It comes in different brand name. We have something called Daflon, we have something called Aldosmin. There are many other brands are there. So each and every flavonoids has this kind of mechanism, and it also works in the hemorrhoid also the same way. Okay. So now we are coming to sclerotherapy. Sclerotherapy is actually a non-surgical, non-invasive procedure. This can be done in liquid form and foam. So how we create a foam? We take an injection, two injections of that. One we have the cetrol. Cetrol is again a sclerosant. So 2 ml of cetrol and 2 ml of saline. So it comes 4 ml, and then 4 ml of plain air. So we connect it to a three-way connector and then we create foam. So after creating the foam, that is actually injected through the superficial veins. Okay. And once we inject that causes irritation of the inner lining of the vein, and it causes it to swell and stick together, causing the blood to clot. So then the vein collapses or shrinks. So in short, they cause sclerosis. That is what I said, the thickening of the blood vessel, and they seal off the blood flow. So basically, if the veins are patent, after sclerotherapy, it will completely collapse and it will seal off. Okay. So the blood is actually rerouted to the healthier veins. So this is how it is, and the scar tissue is then absorbed into the local tissue, and eventually it fades off. So these are the common sclerosants which is used. I would suggest those marked in the red, you should be remembering at least that one. Sodium tetradecyl sulfate, which is what I told it as cetrol, and then hypertonic saline, glycerine, sodium salicylate. If you can't remember everything, at least these four you need to remember definitely, so that it will be useful for your exams. Okay. So the surgical therapy, as we come to the surgical therapy, the TSSA, Trendelenburg stripping and stab avulsion. This is the commonly performed open surgical technique for varicose veins. So nowadays, actually, in my practice, I'm not doing this one, which I was doing this surgery almost 5 years back. As Dr. Venkatesh knows, in Velamal, when I was there, we were doing this one. But after that, from 2017 or 18, everything has been done by laser. So now we are not following this surgery. So in this surgery, what we do is, as I told you, there are from the GSV, all the tributaries are ligated. Okay, and then we just pass a stripper along the GSV, and we just make a small incision below the knee, and then once the stripper passes through, then we just strip off the vein. Okay, so now in other surgery, I mean, like apart from this surgery, in other methods like laser or RFA, what we do is without removing the vein, we do the treatment. So I'll show you the next slide in that. So this is how the TSSA is done. So what we do, we just open up the at the SFJ, and the stripper is passed, and then we make a small incision at the knee, and then we strip it off. The entire GSV is stripped off. Okay, and then we make small incision for the perforated incompetence and tie the perforated incompetence also. So this is the endovenous ablation therapy which I was talking about, which is used to obliterate a varicose vein. There are thermal methods and non-thermal methods. The thermal methods, there are two types, which is actually we do by lasers or radiofrequency ablation. There are two types of thermoablation. So what I formally do in my practice is laser. Okay. So this is the endovenous laser therapy, or we call it as EVLT or EVLA, endovenous laser ablation. Okay. This is what I do. So what we do, this is an alternative for traditional stripping. It is a quicker procedure. There is no scarring. There is very, very less bleeding, and the recovery timing for this process is very short, and it's almost pain-free. The patient get discharged almost the same day or the next day. So this is very convenient as a surgeon for me, and as a minimally invasive surgeon, I always prefer a laser, because this is right now the advanced treatment compared to RFA, which was done for the past 10 or 12 years. So this is EVLA. What I do is I make a small incision on the medial aspect of the GSV on the leg, and then I enter into the GSV with the laser probe. And the laser probe actually with the ultrasound guidance, I just check how far it goes in. And at the point around at the SFJ, once I see the light, I just pull it down around 2 centimeters from the SFJ. And then I just put some saline so that there is no thermal energy which is making the skin to burn. And then after that, slowly I just withdraw, and then I give laser current. So what happens is the entire GSV just closes, it seals off with the laser current. So up to the knee or up to the lower end of the medial aspect of the leg, we can actually do the laser for the entire GSV. So this is actually not possible when we do the stripping. When we do the stripping, we can do only just below the knee, but here we can go almost up to the ankle. Okay. So this is what it is. The laser energy in the form of light, which is usually in the infrared spectrum, is applied, and that energy is delivered in short pulses. Like there will be small pulses, the stop, and then we just keep moving 1 centimeter at a time, and that heats the vein from within and causes it to shrink, collapse, and get sealed shut. And the blood is then rerouted to the healthier veins to the heart. So this is how laser is done. So RFA is little different. What we do in RFA is there will be heat which is generated from radio frequencies energy, and that will be like by passing alternating current between the different electrodes in the catheter, which will be sufficient to produce the heat. So again, that heating, the vein wall dies and the collagen in the wall shrinks and the vein closes to the targeted area. So this is RFA. So the difference between laser and RFA is the mechanism. This is laser is actually different, RFA is different. So but the procedure, the way we do is almost the same. Okay, this is again the same thing. We pass the RFA probe inside, and then slowly we just pull it out, giving the current. Okay. So the non-thermal methods, now the latest methods are these things, but then clary vein, where there is a sclerotherapy is combined with a rotating device which abrades and irritates the intima of the vein. That results in mechanical disruption of the vein and the mechanical disruption of the inner vein wall by rotating device. So this is one method where it has been done, but I think laser is actually superior than this one. Compared to the thermal methods, why people prefer non-thermal is because of the injury, like the thermal injury. So few people, they are afraid of thermal injury, so they go for this non-thermal method, but it is safe actually, comparatively safe. And we have something called coil embolization, where there is a catheter inserted into the affected vein, and then the tip of the coil is made of platinum. The catheter is inserted into the varicose vein, and alcohol is injected. Once alcohol is injected, that's a chemical irritant, so that irritates the inner lining of the vein. So that causes sclerosis of vein, and it's ultimate collapse and closure. So this is again coil embolization, which is actually not frequently practiced nowadays actually. This is one more new technique which is called Chef-on glue system or Venous. If you can type Venous in Google, you will see many studies about this. This is again cyanoacrylate, which is actually injected into the vein, and then that will aid a compression from the surface above by the vein. Like we have to give compression on the outer surface, and then we just put in the catheter, and from the catheter we just put the glue and slowly withdraw. So as we withdraw it slowly with the glue, automatically the vein collapses. So this is the same mechanism as a laser, but instead of using laser or RFA, we use the glue. So again, the same thing, the blood is actually rerouted to the healthier veins of the body. And then the vein is then absorbed by the body's natural process. So this is again vena seal. So this is the one. So you just put the catheter inside, you just apply the glue and slowly withdraw the catheter and see how the vein closes. So the procedure is repeated at 5 centimeter intervals, sealing the vein. So this is how it closes. So these are the different methods of treatment. So not only surgical way for a varicose vein, there are different types of treatment available, and this is just a small glance of what about the varicose vein. There are still many more methods are there, but the most commonly done method is this one. Okay. So how to prevent varicose vein? It's very simple. As I told you, you should be like changing the positions frequently, and for girls, avoid wearing high heels actually, because that looks fancy and fashion, but then ultimately that leads to varicose vein. So eating high fiber diet. Why high fiber diet? Because that is where you lose weight, and that is where you can prevent becoming obese and then varicose vein. Exercising, as I told you, keep exercising, keep yourself fit, and then raising your legs when sitting or lying down. So whenever you take you take rest, or whenever you watch TV, it's better to keep your legs up so that you can prevent varicose vein. As I told you, watching your weight, that's very, very important. So this is my lasertronics mission where I was doing laser surgery. So as I told you, I have a scan mission, and I myself do the scan. I check for the GSV and I make a small puncture, and then I enter through the catheter, and then I put the laser probe, and the laser probe is it's traced up to the SFJ. After I reach the SFJ, 2 centimeter below the SFJ, from there I start the ablation. It'll be a pulsed current. Slowly I withdraw the catheter, and once I come closer to the skin, I withdraw, and then I'll check for the bleeding. And once if there is no bleeding, we can just do the dressing. So after that, we do a compression dressing. After 1 or 2 days, if you see, there is no visible veins and there is no any thermal injury, and it gives excellent cosmetic result, as well as the patient is pain-free. The patient is discharged on the same day or probably the next day, depending upon. I usually prefer doing this under spinal anesthesia, because a few people will not be accepting local anesthesia because that is very painful, because we need to put multiple injections. Okay. So these are some of the references for this presentation, and thank you for your listening. I hope you understood something about varicose vein.
Thank you, sir.
Yeah.
Thank you, sir. So that was a wonderful session, sir. I hope the delegates learned a lot on this topic, and we would like to have more sessions with you in the future, sir.
Sure, sure.
So I would also like to extend my heartfelt thanks to Dr. Christopher, sir, for accepting the invite amidst the hectic schedule and enlightening us with this knowledge. I would also like to extend my gratitude and thanks to Dr. Ablasan, sir, Dr. Venkatesh Karthikeyan, sir, and Dr. Prashant, sir, for providing us this wonderful opportunity to conduct the webinar. We also thank Clarinet for looking after all the technical aspects of the session. The recorded session will be uploaded in the YouTube channels of IMAJDN and SNO Tamilnadu in a week, and the e-certificates will be sent to the delegates in a couple of days. Thank you. Thank you, sir.
Praveen, is there any questions from audience?
No, sir. From the delegate side, Clarinet has said no question from delegates.
Debalina, is there any questions from audience side?
No, sir.
Okay, great. Okay, sir. Thank you so much, Christopher, sir, for sparing your valuable time for us.
Yeah, Venkatesh. I mean, see, varicose vein is a very big topic. I tried to do justice in this, half an hour or 45 minutes. Yeah, I tried to do some justice, but then it is a very big topic. There are so many evolving concepts in varicose vein, and there are so many new procedures also. So whatever I have come across, I have put everything into one presentation I have told. But then this doesn't end actually. They are evolving, and they keep on learning. So maybe probably after 1 or 2 years, if you ask me a presentation, that time I may be doing something else. So
Or maybe when I graduate, things may change drastically.
yeah, maybe change. Yeah, so it keeps on evolving. So the surgical field is like that. So I hope if somebody is interested in becoming a surgeon, definitely they need to watch out about varicose vein. This is one of the main surgeries where patients frequently come to a clinic. Okay, and to as for a vascular surgeon, this will be very common procedure. So you need to keep studying about varicose vein. And more than that, becoming a surgeon as an MBBS student, to clear your exams, definitely there will be a varicose vein case in your exam, and definitely there will be questions related to whatever I have told you guys. So please learn about varicose vein. So once again, I thank Venkatesh and the team for giving the opportunity to talk on varicose veins, and I thank Praveen for conducting this. So thank you guys. Thank you.
Thank you very much, sir. Thank you. It's a pleasure, sir. It's a pleasure. Thank you.
Yeah.